For the continuation of the case presentation.
Thank you very much. Those were really very interesting cases. And I would like to add one thing for metastatic melanoma. Rarely, metastatic melanoma cells can be estrogen receptor positive. We are in the process of evaluating our metastatic melanoma cases in our breast, and 6% of our cases are ER positive. So please don't rely on estrogen receptor positivity for that. The case I selected for today's discussion is an in situ lesion. The patient is a 55-year-old woman. She presented with a punctate microcalcifications on annual mammogram screening. She had a negative mammogram a year prior to this. And because of the suspicious microcalcifications, she underwent a stereotactic corneal biopsy, which revealed ductal carcinoma in situ. And on the basis of this diagnosis, she underwent an excisional biopsy. And this is her mammogram. As you can see that here is the areas of microcalcification. It is clustered and it is punctate, so it was very suspicious for in situ carcinoma. And this is the excisional biopsy that we received. Here is the biopsy site where the clip is. And there wasn't anything palpable. There were some areas of fibrosis around the biopsy, but the rest of the tissue was pretty unremarkable on gross inspection. So we put mainly the area of the previous biopsy with the margins and the representative sections of the remaining slices. So here is the biopsy, and here is the margin. On intraoperative evaluation, we felt that the margins were away from the biopsy site, so this was put for permanent sectioning. And here is the sections from the excisional biopsy. As you can see, there is an in situ proliferation of monotonous cells. Involves both ducts and the lobular units, and there is extensive comedotype central necrosis associated with microcalcifications. It's a duct with in situ carcinoma with comedonecrosis, and higher magnification of the in situ carcinoma, quite monotonous cells, very evenly spaced, very round nuclei. So at this point, our differential diagnosis was DCIS versus lobular carcinoma in situ, and we did an E-cadherin staining, and carcinoma in situ cells are negative for E-cadherin expression. So our diagnosis on this case, with the help of E-cadherin staining with the positive internal control, our diagnosis is pleomorphic lobular carcinoma in situ. I would like to review the in general lobular carcinoma, and then I would like to discuss the pleomorphic lobular carcinoma. When we talk about lobular carcinoma in situ, it is proliferation of uniform cells involving predominantly lobules, and they can extend into the ducts. In the original descriptions, we always had two types of lobular lesions, type A and type B. Type A is the small uniform cells that we always think of the classical lobular neoplasia. And these are usually small nuclei with bland nuclear features and no nucleoli. And type B is the larger cells with some nucleoli and very prominent nucleolus. And here is an example of typical lobular neoplasia. Here is the duct, and here is the lobular unit extension into the ductal space, and we call this pegydoid extension. And the uniformity of the cells is the hallmark of lobular neoplasia. Again, another example of pegytoid extension. So the solid proliferation of uniform cells is the hallmark of lobular neoplasia. And the main differential diagnosis of lobular carcinoma in situ is the ductal carcinoma in situ. Even though on the basis of nuclear features, sometimes we could make that distinction, in the low-grade lesions, the only criterion that I can reproducibly identify lobular versus ductal lesion is the absence of secondary lumen formation. So by definition, if we identify secondary lumen formation in any intraductal lesion, that's a ductal lesion. So if I see that, I don't really pay attention to the nuclear features. So definition of DCIS is presence of lumen formation by the neoplastic cells. So after that, I will get the nuclear features and try to grade the DCIS. If I cannot see any lumen formation in any solid low-grade proliferation, it can be either ductal or it can be lobular. A lot of people talk about uniformity of the cells, how rigid the cell borders are. In my opinion, those are all fine, but they are not diagnostic. So you really cannot make a distinction. So if it is a small proliferation, small cell proliferation in a solid pattern in situ carcinoma, I will not try to make it into ductal carcinoma in situ or lobular carcinoma in situ without equaterin. I rely on equaterin on those low-grade lesions without any lumen formation. So to me, the lumen formation is extremely important. The loss of cohesion and presence of the type of nuclei, they are all fine, but to me they are not diagnostic, even including intracytoplasmic mucin. One very important thing that I see this over and over again by our trainees or people who are sending their cases for a second opinion, that especially in core biopsies or in a margin of sections, the cautery artifact in a normal lobular unit or sometimes with a mild ductal hyperplasia can give you an effect, it looks like lobular neoplasia. So please, if you have a single duct at the edge of the section, don't make the diagnosis of lobular neoplasia, because the cautery artifact can look like lobular lesion, including lobular in situ carcinoma. So don't make that. So cautery artifact is something very important to remember. And in this case, it was right at the edge, and then this area was called LCIS, and there was nothing else in the rest of the tissue. So we said that this is a cautery artifact. If you have these plasmacytoid cells, and if you have this intracytoplasmic lumen formation with targetoid mucin, again, it is very diagnostic of lobular lesion, but even ductal carcinomas can show this. So based on cytology alone, I think it's very difficult to differentiate lobular versus ductal carcinoma in situ. One very important point that I'm going to try to make today is that sometimes we focus on too much on classification of in situ lesion and we miss the invasive cancer. With lobular neoplasia, especially lobular carcinoma in situ, it is very common to have small foci of invasive carcinoma. And I mean, at least once or twice a year, I always get a consultation, and the question is it a DCIS or LCIS? And then there is invasive carcinoma there. And then people are so concerned about classification of the in situ lesion, they miss the invasive component. So when you make a diagnosis of an in situ carcinoma, please look around for invasive tumor. So in general, we said this is the type A, which is the classic lobular carcinoma in situ. Type B is slightly larger nuclei, and then when you have significant cytologic atypia, then we make it pleomorphic lobular carcinoma in situ. And then we have groups of lesions that we collectively say that these are the lobular carcinoma in situ variants. Some people call it lobular carcinoma in situ with signature cells. Others call it lobular carcinoma with central necrosis, extensive lobular carcinoma in situ. And these are all terms to describe the lesion, which is not typical lobular carcinoma in situ. So in my opinion, to classify them as variants of lobular carcinoma in situ is acceptable. And another term some people use is pleomorphic lobular carcinoma with apocrine features, meaning that the cytoplasm has eosinophilic appearance, and usually it's abundant cytoplasm. But again, this is a variant, so it's not a classic lobular carcinoma in situ. So you call this pleomorphic carcinoma in situ, lobular carcinoma in situ with apocrine features doesn't really make any difference as long as you classify it as a variant. So when we diagnose pleomorphic lobular carcinoma in situ and corneal biopsy, we recommend that these lesions should be treated as ductal carcinoma in situ. So in our case, the initial diagnosis of DCIS really did not create a major clinical problem, because both DCIS and pleomorphic LCIS on a core biopsy should have an excision. And it has been reported that up to 25% of patients, so 1/4 of patients who have a diagnosis of pleomorphic lobular carcinoma in situ on a core biopsy, when they have excision, they have an invasive carcinoma. And when we think about the invasive carcinoma in lobular carcinoma in situ, we always say that it could be anywhere, but in pleomorphic lobular carcinoma, invasive tumor is usually adjacent to pleomorphic lobular carcinoma in situ. So we think of pleomorphic lobular carcinoma in situ as pretty much like DCIS, precursor lesion, not a high risk lesion. So the risk of recurrence for pleomorphic lobular carcinoma in situ is more similar to ductal carcinoma in situ. Another question comes in when we have excisional specimens, when we have pleomorphic lobular carcinoma in situ close to the margin. Does this patient need re-excision or not? Right now, we don't have extensive data in the literature, and what the data we have suggests that yes, since these lesions are more like DCIS, re-excision with negative margin is recommended. Is it mandatory? We don't know, because the data is not as solid as DCIS. But our recommendation right now, if we make diagnosis of lobular carcinoma in situ and an excisional biopsy, and if the lesion is at the margin, we recommend re-excision. And if you look at the biomarker profile of classical lobular carcinoma in situ and pleomorphic lobular carcinoma in situ, usually it's very similar. Majority of pleomorphic lobular carcinoma in situ and pleomorphic invasive lobular carcinoma are ER and PR positive. The only difference is that pleomorphic lobular carcinoma in situ has very high expression of HER2 positivity. So these lesions are HER2 positive. And their HER2 positivity can be identified with immunohistochemistry, or it can be done with FISH, but usually they are HER2 positive. And they are usually when they are associated with invasive lobular carcinoma, the invasive component is also pleomorphic, so it's not invasive carcinoma classical type. So even that is HER2 positive. So we have to be careful about that, because great majority of classical invasive lobular carcinomas are HER2 negative, but pleomorphic invasive lobular carcinomas can be HER2 positive. So this is another example of pleomorphic lobular carcinoma in situ. In order to establish this diagnosis, we really need to see significant cytologic atypia. And sometimes DCIS and LCIS can coexist. And most of the time, this can be identified on the basis of morphologic H&E features, but it's always nice to confirm that with E-cadherin staining. Here is a combined DCIS-LCIS case, where the DCIS cells diffusely express E-cadherin and LCIS is diffusely E-cadherin negative. I personally extensively use E-cadherin staining. And in addition to E-cadherin staining, which is a negative staining, as a pathologist, I always like to see positive staining as opposed to negative staining, because it's always more difficult to base your diagnosis on a negative staining than positive staining. We can use P120 staining. DCIS typically shows this membranous staining for P120, and LCIS shows this cytoplasmic staining. So it's a good marker to confirm your E-cadherin staining. High magnification of the same case, showing the DCIS membranous staining. This shows the intact E-cadherin pathway. In contrast to lobular carcinoma in situ, P20 staining is cytoplasmic. And sometimes even in the same duct, we can have both ductal and lobular carcinoma involvement. Excuse me. So here, even on H&E staining, we can see this cohesive cells around here is LCIS, and in the center there's an extension of DCIS from the adjacent duct. And before, as I mentioned, this second lumen formation is the hallmark for DCIS diagnosis. And this is what I'm saying, this secondary lumen formation. And with E-cadherin, of course, you can confirm that finding. So in summary, for lobular carcinoma in situ on core needle biopsy, if it is a classical lobular carcinoma in situ, then we look at the clinical presentation. If it is an incidental finding on a core needle biopsy, meaning that it was not the target lesion, for example, if patient had a mass lesion and had an ultrasound-guided core needle biopsy, and the mass corresponds to fibroadenoma, but in addition to fibroadenoma, there's a focal area of LCIS, we call that incidental finding. So the lesion was not the target, but we found incidental LCIS and a core needle biopsy. Then we present these cases in multidisciplinary setting, and either observation with chemoprevention can be performed, or the rest of the breast can be identified and then under surveillance, or can be discussed with the patient based on patient's family history and other risk factors. If the patient is a high risk, bilateral mastectomy can be considered. But this is for incidental lesions. If classical lobular carcinoma in situ found on a core needle biopsy and it is associated with abnormality, or there is a discordance with the clinical presentation, or patient is a known high-risk patient, then the excision is recommended to identify if there is any more aggressive, more advanced lesion, i.e. an invasive carcinoma. So then excision is recommended. But if it's a variant of lobular carcinoma in situ, it doesn't really make any difference. It can be pleomorphic lobular carcinoma, lobular carcinoma in situ with necrosis, apocrine differentiation, signet ring type, whatever. It is non-classical lobular carcinoma in situ. Our recommendation is always to excise, and we warn the surgeon, say that this lesion is not typical lobular carcinoma in situ, so the margin in this case is very important. So we pretty much treat these patients as DCIS patients. And most importantly, we look for invasion if we are making diagnosis of variant of lobular carcinoma in situ. This is a very important point. So you really have to look for invasion. So take-home messages from this case: patients with variant of lobular carcinoma in situ should have a excision if the tumor is within 2 mm of resection of margin. E-caterin and P20 are very helpful stains. And since pleomorphic lobular carcinoma in situ is commonly associated with invasive cancer, specimens should be evaluated very carefully to look for areas of invasion. Any questions on case number 1? Are you talking about invasive carcinoma or in situ? Correct. If we have in situ carcinoma only, either as a DCIS or lobular carcinoma in situ, we do not perform peritoneal staining. So that was only for like a study to look at the biomarkers. But there is no indication to perform peritoneal staining in situ carcinomas. But if there is an invasion, even it's a microinvasive carcinoma, we always perform immunohistochemistry.
Same for ER or PR? Same.
For ER/PR staining, again, we do for pleomorphic lobular carcinoma in situ because that is similar to ductal carcinoma in situ. If the in situ carcinoma cells are positive, patient can have hormonal therapy. Okay. Case number 2. This is a 56-year-old woman who underwent an ultrasound-guided core needle biopsy of the breast after she had a fine needle aspiration in which the diagnosis of atypical papillary lesion was rendered. So first patient had FNA, the diagnosis of atypical papillary lesion was made on FNA, and then she had a core biopsy, and diagnosis of ductal carcinoma in situ was made on the core needle biopsy, and she underwent a segmental resection. So these sections are from her segmental resection. Here there is an in situ proliferation, and here is the higher magnification, which I'm going to show you the higher magnification showing the cytology of intraductal carcinoma cells. But even at this magnification, you can appreciate that there is definitely lumina formation. So this is a ductal carcinoma in situ. There is focal necrosis here. But the main area that I would like to discuss with you is not the area of DCIS, but area adjacent to DCIS. Just like lobular lesions, when we make the diagnosis of DCIS in either core biopsy and excision, our main concern is if there is any stromal invasion. So we always look for invasive component because it is going to change the stage significantly and it is going to change the therapy significantly. So in this case, we have the in situ carcinoma here, and adjacent to that, there is a proliferation of small and intermediate side clusters associated with some stromal reaction. High magnification of that area shows that there are some ductal structure, smaller clusters associated with some stromal reaction and some inflammation. And higher magnification of that area again shows there is some tumor nuclei. It appears to be undergoing necrosis, but the clusters are very irregular, so it is quite suspicious for invasive carcinoma. Actually, this is another consultation case that we received in our institution, and this case came with a diagnosis of 3 millimeter of invasive carcinoma adjacent to ductal carcinoma in situ. And higher magnification of some of the irregular clusters show that there is some clear space around these clusters, and associated with this stromal proliferation, some vascular spaces, looks like granulation type tissue. So since this case came to us with a diagnosis of invasive carcinoma, and the person who received the case said that, well, I don't know, I'm not sure if it's invasive or not. If our differential diagnosis is invasive cancer or versus non-invasive cancer, the best thing to do is to do immunohistochemistry for myoepithelial markers. And in our institution, we use smooth muscle actin and P63 as myoepithelial markers. So we did, by the time we received this case, we had the immunohistochemistry. So there is an internal control which works pretty nicely for P63, normal dots showing the intact myoepithelium. And here is the lesion that we have. These are the internal controls working pretty nicely, but all these clusters are lacking myoepithelium around it. So the person who was sending the case saying that, we have this irregular proliferation of tumor cells around the CIS, and they lack myoepithelium that should equal to invasive carcinoma. And our diagnosis in this case actually is epithelial displacement associated with DCIS, not invasive carcinoma. So I will try to convince you that our diagnosis is correct. So displacement of benign and malignant epithelium into stroma and lymphovascular channels is a well-recognized phenomenon. And displacement of DCIS into stroma may be misinterpreted as invasive carcinoma, as it was done in this case. The incidence is very difficult to ascertain because most of the corneal procedures result in benign diagnosis. Because of that, we do not have any excision on those. But for those patients who have a malignant diagnosis and an excision, displacement can be seen up to 35, 1/3 of the cases. So epithelial displacement is not a rare phenomenon. It is reported to be less common on corneal biopsies performed on vacuum-assisted devices than automated biopsy devices, and likelihood of finding displaced epithelium is related to the interval between corneal biopsy and excision. So the sooner the excision is done, there's a higher chance to identify these displaced epithelium. Papillary lesions usually more prone to this phenomenon. As I indicated in her history, the initial diagnosis was papillary lesion. So she had a DCIS with focal papillary features in her initial corneal biopsy. And it was thought that papillary lesions are more friable and can be broken very easily due to trauma of corneal biopsy. Large intracystic papillary lesions may also be more prone to displacement as a result of intracystic pressure. And then when we biopsy these lesions, the fragments can go into stroma quite easily. This is another case of epithelial displacement. This is a corneal biopsy, which is performed as a second biopsy after fine needle aspiration. As you can see that there are these small fractures of tumor and associated with some stromal reaction. And most of the time you recognize these epithelial displacement. First, you recognize the area of previous biopsy with these foreign body giant cells and with some inflammation and more granulation like stroma rather than desmoplastic stroma. Here is another case. There's an area of fibrosis. It's almost like a biopsy tract. And then you have these clusters of tumor cells in the stroma by itself. And some of these tumor cells show more eosinophilic cytoplasm, so some of these cells probably undergoing apoptosis. But when you see these clusters, individual cells embedded in this fibrotic stroma, but it is not really desmoplastic stroma, then you really have to question epithelial displacement. This is an epithelial displacement. And seeing these clear areas around the tumor clusters is a very important clue. So this is a common pitfall for small glandular proliferations or invasive carcinomas. Sometimes normal epithelium, the proliferating like intraductal epithelial cells can also show displacement, but it's extremely rare. Most of the time it's malignant epithelium. And most important thing is that since these are displaced tumor cells, and even in normal epithelium, so these are displaced cells from a proliferating epithelial lesions, they lack myoepithelial cells around it. So if you're questioning the invasive carcinoma versus epithelial displacement, please do not do immunohistochemical markers for myoepithelium, because this will confuse you more than it will help you. So in a differential diagnosis of displaced epithelium, immunohistochemistry is not a helpful thing. Clinical history of previous needle procedure is very important. So if there is no needle procedure history, I'm not going to make a diagnosis of displaced epithelium. No way. So you have to make sure that there is no invasive carcinoma. But if there is either FNA or most of the time it's a corneal biopsy, then it's very important. Associated histologic changes of previous biopsy, stromal granulation tissue, inflammation, presence of foreign body giant cell reaction around these suspicious glands is very important. One other important clue is that histologic similarities of displaced epithelium and adjacent pathology. So if you have a high-grade carcinoma, ductal carcinoma, and then the proliferating cells are a different histology, then you have to question that. So it has to be very similar to displaced cells, similar to invasive or in situ carcinoma adjacent to it. And again, please do not use immunohistochemistry as an evidence for invasion. Thank you very much for your attention. It could be. The main thing is that, like, I can go back real quickly. When you look at invasive papillary carcinomas, even when they are a lot larger than this, you really need to see a little more uniformity among the papillary structures. It is, but then when you see, look at the stroma, how it is associated with almost like nuclear debris, inflammatory cells, and here, like having these cleared spaces around it. And most of these are like granulation tissue type vascular spaces. I'm sorry, the name? We interpret this actually biopsy site changes because this is, yes, it is necrosis, but it is associated with nuclear debris and granulation tissue. Biopsy, correct. So this is, we are interpreting this as like a previous biopsy site. Any other questions? That is the reason I am showing this case, because it is difficult. I'm saying it is difficult. And then the other very important feature for me, look at that. There are these big clusters and then these single cells. I mean, it's very unusual for a small invasive carcinoma to show this. It is difficult. I agree. And that's the reason I wrote it. I don't follow up for 2 years, which is not enough follow-up. I'm following this patient, but it's... if in 5 years, when she develops metastatic carcinoma, I'll come back and present it, promise. Promise.
Okay, any more questions?
How often you can have this epithelial displacement with fine needle aspiration?
Very rare, very rare. As I said, even with vacuum-assisted biopsies, we don't have it. It's automated gun is more frequently, which in the United States, automated gun now it is not used that often. Well, I think this concludes our session then, and I would like to thank everybody for their attention and organizers. I think it was a very successful session. Thank you very much.
Thank you very much, Dr. Sayin, for the interesting cases and nice presentation. Thank you, professors and colleagues. Meet tomorrow, inshallah, at 9.